talked to her about like when you have the removal of hormones at such a young age, and obviously it was one ovary, like you're still producing hormones. But in general, a lot of people that I talk to on social media have had hysterectomies, full hysterectomies at like the age of 30 something. Mm-hmm. And luckily it's becoming more common that people are getting put on HRT after that. But even partial, I mean, there's a lot of statistics right now around you have a partial hysterectomy, you are going to enter menopause on average 1 to 3 years earlier. And what the problem is that we're seeing is how long people are spending without hormones and the effects of that. And that's going to be covered today. But she talked to me, she's like, well, I'm taking calcium. And I'm like, Mom, it's not calcium. Like you need hormones. And she's older. And so we had that discussion of get a heart scan, make sure there's no potential clot, consideration. Yep. But low dose estrogen is safe, even when applied later in life. And they've done research studies like in nursing homes that have shown cognitive improvement and all of this improvement, even when you want it later. So just something to consider. But yes, I am very, very fired up about this stuff.
Yeah. Well, it's also like taking your vitamin D and your K, right? Like you need things to get to the right place. If you're taking calcium, you got to take it with other things to make sure the cofactors are there so that you're actually mineralizing the places you want to mineralize and not sending it to places that you don't want. So yeah, I'm a big believer. I think everybody should be getting bone density scans, calcification tests, all those types of things. If your cholesterol is really like wacky, ask for, a fractionated lipid panel. Like you have the right to do those things. This is your health. You do not have to accept a blanket statement of high dose, calcium, vitamin D, and or a statin. So let's talk about osteoporosis. So this is what we would deem as more of like a porous bone. So I really like the analogy here if you think of porcelain, right? So my mom and dad would always give these like porcelain figurines, let's call them that. And so they seem really hard on the outside, but they're hollow on the inside, right? They easily break. And so we can think of these as almost like cavities that develop in aging bones, and then we slowly, degenerate. So until the age of 25, more bone is formed than lost. But after the age of 25 to the age of 30, women reach peak bone mass, and that maintains steady for about a decade. Once we hit the age of 40, our bone formation slowly declines. And at 50, the bone is less and less and less. And so some of the things that we know to be true is that for bone health, resistance training and rebounding and stressing the bone is one of the most beneficial things that you can be doing. And this is why we talk a lot about rebounding, right? Resistance training. And even for those who feel like this joint pain, like swimming, like do something. But the most troublesome areas are going to be your spine and your hips. They take all of our weight, right? Hip fractures in particular increase the risk of death. We know that amongst older people, 20 to 25% of people who have hip fractures, especially in their 70s and 80s, will die within a year. And many studies have confirmed this too. Hip fractures, much higher likelihood of death. My grandmother, I remember she fell and she broke her collarbone, and it took her months and months and months and months to heal from that. I don't even know if she ever fully healed from it, right? So the development of osteoporosis in the women over age is 4 times more likely than men. Why? Probably because of that low estrogen that Becca just mentioned. Estrogen is important. And then we would say too that their hip fractures occur 5 to 10 years earlier than most men. So stability is going to be important here. This again, thinking about things that you can do to prevent all of this beyond, what we're going to talk about here today is making sure that you are resistance training, you're rebounding. That can be a simple rebounder. You get a little trampoline at home, get one with the bar. I've had some of my older clients do that to stress the bone a little bit. It doesn't have to be like pounding your joints out, right? Running on pavement or anything like that. But exercise is also going to be really important for what we're going to talk about with density and resiliency.
Mm-hmm. Yeah. And exercise is something that you want to be doing earlier on. And we'll kind of talk about that at the very end, but it's not something that's going to be able to reverse osteoporosis once it starts. So you want to be doing that in your 30s, 40s, so that when you go into this low hormone state, you have developed strong bones, you have developed strong ligaments and joints that can handle things, because those also support the bones, obviously. So we need to discuss first what bone density versus bone resiliency is, to understand why calcium is not necessarily the answer for preventing fractures, for preventing osteoporosis. So the structure of a bone is kind of like a structure of a tall building. So you have these girders of the building that are kind of comparable to like collagen fibers within the bone that provide this structural support, right? And then, allowing the bone to undergo stress and bend without breaking, because our bones have somewhat of this like ability to bend. It's important that they're able to do that and take, like Liz was saying, that rebounding force, because if they cannot bend, they break. And so the flexible framework, that ability to bend, is called an osteoid. And calcium is deposited on and in the osteoid. That creates the outer shell of the bone, like the external face of the building, okay? And the calcium in that outer shell provides a strong shield for the softer osteoid and aids in the load-bearing potential of the bone, but it does not aid in the bone's ability to bend without breaking. So an increase in calcium actually is an increase in stiffness and supportive strength, but it actually decreases the bone's flexibility. So when women age, this thick elastic collagen fiber inside the bone becomes thinner and more brittle. And the tensile strength, which is what allows the bone to withstand force without snapping, diminishes. And so we also need to distinguish, again, to help us understand the calcium situation, osteoporosis and osteomalacia. So there was someone that was very, very smart. His name was Fuller Albright. And in 1940, he basically distinguished osteoporosis and osteomalacia, which is basically what we know as rickets. A lot of people know as rickets in children. And that's basically caused by the bone's deficiency of minerals. So with osteomalacia, the bones lack strength conferred by calcium during a person's first 2 decades of life. So basically, it can't bend on exposure to stress. So over time, physicians, though, started to basically conflate osteoporosis and osteomalacia. And this led to this blurring of the two conditions, so that osteomalacia is essentially a deficiency of enough calcium and vitamin D. Osteoporosis, like I just said, is a essentially hollowing of the bone. Calcium does not help that. And so calcium is crucial for the development of strong bones. That's why we talk about, adequate calcium for children, young adults. But once bones are formed, additional calcium neither treats nor prevents bone loss. So Albright saw this, and he said that of his postmenopausal osteoporosis situation that he saw in all of his clients and patients, it was not caused by a process related to the metabolism of calcium or other minerals. So high intake of those minerals, like calcium, with or without vitamin D, would have no real benefit.
Craziness. That's not what your doctor says, though. Come on, Becca.
No,
You want me to challenge my doctor? Well, let's ask the science. Let's see what the research says. So there was a major study by JAMA, a huge network. You guys can look them up. I think that if you are in the health space, you know who a JAMA is. But this was done in 2017. And so there was 33 randomized trials involving 52,000 people that compared the incidence of fractures in people taking supplements versus those who were taking a placebo or just not getting any treatment. And they found absolutely no association between calcium on its own, vitamin D on its own, or calcium and vitamin D together with the incidence of fractures. And this is because, again, calcium does not affect the interior architecture of the bone. Calcium affects the density, not resilience. And it's resilience that matters, right? Rebounding, being resilient. I always think about in terms of mobility work, we're always reaching. If you guys have ever taken a yoga class or a mobility class, you're reaching for one extra degree. You're not reaching for, far out there, but over time, you're able to, have a wider range of motion. This makes you more resilient. I remember that when we moved into this house, which would be 8 years ago, they were redoing our floors. We were here cleaning up and I fell down the stairs. And the way that I fell down the stairs was not good. I definitely should have broken something, but I was teaching mobility at the gym at that time, multiple days a week. And I really think because my body knew, hey, I've been in this range of motion before, it's okay. Hurt like hell, right? But it didn't break anything. And that's what we want, obviously. We want to be resilient. So again, it's that range of motion. But anyways, I digress here. So resiliency is what matters. And those are ways we can make ourselves more resilient. But what does this help? So both estrogen and progesterone stimulate bone formation and inhibit bone loss. And to date, no therapy studied has been better than HRT in preventing osteoporosis and fractures in the spine and hips. Many, many studies have confirmed this. One showed that taking estrogen had a 35 to 50% reduction in the likelihood of having a fracture. Another showed that estrogen slowed or even stopped bone loss and was the only well-established treatment that reduced the frequency of osteoporosis, fractures in menopausal women. And the WHI investigators themselves acknowledged that this existed too. This benefit existed. They reported a 33% reduction in hip fractures amongst those on HRT. I'm happy that all of the fear around HRT is starting to simmer down because there's been, a lot of the people coming out with that women's health study initiative that have said, they skewed the information. And so it's sad, right? Because there's so many women that probably could have benefited and maybe extended their lifespan if they would have been on hormone replacement therapy. So these are all things that we want you to have in your toolbox because you may need to be talking with your doctors and recognize that estrogen, and Becca can share, Estrogen Matters. It's a really great book she's reading. I'm going to read it soon because I had a client last week. She's in her 30s. Her estrogen is really, really low. She's experiencing vaginal dryness, right? Poor lubrication. Like, she should not be experiencing these things. She's in her 30s, mind you, like I said. And so she was like, she didn't even know like how important estrogen is, to the body. So we had to kind of go through that. And so maybe we'll take a deep dive in another podcast on estrogen by itself, because I think it just gets such a bad rap in terms of like ovarian cancer, breast cancer, and uterine cancer. And it's not the estrogen.
No.
It's that you're not clearing it out. You're not detoxifying things. Things are building up in the body. You're stuck in what we call mTOR pathway. We'll talk about that some other time, but estrogen is not always the one to blame.
Yeah. I actually saw a really not weird, but crazy statistic the other day that I think it was something around since 2018 or something like that, tens of thousands of women have died that should not have died because they were not on estrogen HRT. Like, they had stopped their estrogen HRT and in turn saw basically the problem, and I'm going to talk about this, the problem when you stop hormones is hormones stop in the body. Like, it's not like they build up and then you have this reserve of hormones that you can keep forever. Like, once you take HRT, you need to be on it for the rest of your life. And I think a lot of people get worried about that. And I love Dr. Mary Claire. She talks about this. She's like, I'm going to die with my estrogen patch on. Like, and she mentioned regarding the more awareness of HRT, she said, she's an OBGYN. And she's like, if I were to be in a room full of OBGYNs right now, 10% would probably be on the board of HRT is good. And so we still have a ways to go. Like, it is still something that we need to be educating ourselves about so that we can better advocate for ourselves. Because when it comes to osteoporosis, for estrogen to reduce the risk of fractures that occur usually 10 to 30 years after menopause, women must be on HRT for at least 10 years, usually the rest of their lives. And I say this because most women, 86%, who experience hip fractures experience them after the age of 65. Many women only take HRT in their 50s to ward off the symptoms of menopause. But like I said, once you stop taking hormones, they're out of your body. Like, they will not bring you the benefit. The risk goes right back up. And so we need to stay on them long term. And you can. It is not bad for you to stay on hormones long term, as long as you are not having other side effects, right? And you shouldn't, as long as you are healthy. So the big thing here, this is where things get juicy. Should we even be concerned about osteoporosis? So I'm going to ruffle some feathers. There has been an obvious increase in lifespan. We are not going to deny that. Like, people are living longer. And with that, there has come this desire to fix what is a natural aging process.
Biohack everything.
Biohack everything. Cold plunge all day long, red light therapy on your face all the time.
Oh my God.
Like,
oxygen chambers, anything and everything that costs thousands and thousands of dollars.
And again, I don't think that that's a bad thing, right? But it is an opportunity for those not only that are aging, but also pharmaceutical intervention, right? Which in this case has produced results that are inconclusive at best with osteoporosis. So basically, we are seeing a manufacturing of new diseases that allegedly warrant drugs that Big Pharma just happens to have developed.
We already have vaccines for things that haven't even come to fruition yet. I wonder why.
So the question became, where on the continuum of bone loss, which happens to everyone, like I mentioned, as a part of natural aging, does it become a disease? How little is too much? And so it started with an arbitrary answer, which I will say, believe it or not, happens a lot. There are a lot of arbitrary levels that are now...
Same thing with hormones. We learned that, right, from Dr. Rob. It's what sounded good, apparently. Yes. So it's like you were saying, staying on these things without other side effects, and it's really your symptoms, how you feel, versus even what's in range or lab markers. Because when we're deciphering, for example, like Dutch test, like the number one thing that we always ask is like, what is going on with the person and their symptoms, and what do they want to get out of this? Because For some individuals, like they feel okay with moderate levels of hormones, but they're balanced, right? Where others feel like total crap. And it's like, man, maybe you do want to start, a little bit earlier in life supplementing these things. So anyways, continue.
So anyways, the level that they decided on the continuum of bone loss was a bone mineral density test score that was a 2.5 standard deviation below that of a healthy 30-year-old. So standard deviation is basically like how far away from the average is it? Mm-hmm. And that meets the diagnosis, quote unquote, of osteoporosis. And this was simply supported to be a benchmark for estimating kind of like the prevalence of osteoporosis. They were trying to decide how common is this happening now. It was technically not intended to be the sole clinical criterion for determining drug treatment. But then it became, okay, if 2.5 is bad, isn't 2.0 or 1.5 like pre-bad? Isn't that leading into being bad? And accordingly, osteopenia emerged, which a result between 1.0 to 2.5 became below that of a healthy 30-year-old. Hear this, though. Osteopenia has no clinical significance and does not even predict the risk of osteoporotic fracture. Now people are fearing that they're going to wither away when their bone loss for their age is actually completely normal. And there have been like people that have said osteopenia literally is not a real thing. Mm-hmm. Yeah. It is not a real thing.
Yeah. Yes. I've heard that several times, and it's fear. I think this is the thing, is like fear mongering. We've seen that happen a lot more in the recent years. Let's put it that way. And you just got to know what's right for you. Follow your gut, follow your intuition, do the research. So anyways, the prescription that they give is bisphosphonates, which seem to be an alternative to HRT, but they do nothing for osteopenia. They can avert osteoporosis in women at high risk and also stabilize bone loss in women who already have it, but the side effects are pretty unpleasant, and some are worse than HRT. So the most common side effects seen with that is abdominal discomfort, muscle joint pain, fever, flu-like symptoms, insomnia, kidney disease. 70% of people that start the drug stop it within a year. And there's actually, for those who take it long-term, increased risk of hip fractures. So that's kind of scary, right? So they fear monger you into taking something that's going to long-term increase the risk of fractures. Kind of sounds like statins.
Right.
Interesting correlation here. If you guys want to listen to all the juicy details about cholesterol and statins, we can link out some previous episodes that we've done with other doctors who bring the research and the science, but we have also done our own that we shared, and Metabolical is a really great book to reference because they share how statins don't actually touch the issue that's going on. And so it's kind of that, I would say, like silent killer, because you're getting levels on labs maybe in a better range, but what's happening in the mechanism in the body, and let's say those small particles that can be very damaging, those actually aren't changing. So anyways, the bottom line.
Yeah, so let's recap here. Calcium supplements, which millions of women take in hopes of fending off loss of bone density, are ineffective at preventing postmenopausal osteoporosis or fractures because they do not affect that resiliency. They do not affect that ability for the bone to bend without breaking, and they actually make that worse because they stiffen the bone. Exercise can improve bone strength and resistance to fractures in premenopausal women, but it does not improve bone strength or resistance to fracture among postmenopausal women who are not on HRT. So like I said, it's very important to head into menopause with a good foundation of bone strength, because yes, when you are in those developing years, you can build more bone strength. You can build more flexibility. It's extremely important to do so. Currently, HRT is the most effective intervention with the fewest side effects for preventing or diminishing the development of osteoporosis. And I'm not saying that calcium and vitamin D cannot be helpful in general or important to bone health. But for this purpose, they are not the answer. And so maybe you have some new information now to make better choices, to not waste money on supplements,
to get some other testing, right? And some other answers, and, recognize that if your OBGYNs aren't getting the job done in terms of testing your hormones, like I have 3 situations that have happened in the last 6 weeks where OBGYNs told my clients that it wouldn't give them any valuable information, and it's absolutely angering. One of them is on progesterone and thriving when she was really, really struggling before. The others are doing phenomenal just with some of the other things that we're doing naturally to support their body, to balance things out. And a lot of it comes down to stress management, right? Like your adrenals and DHEA production and a variety of things. But it's pretty angering that some of these OBs won't do. I don't know. Becca and I are very lucky. Maybe it's the way we ask or talk or educate our OBs on certain things. They do run all of the blood work, even things I've asked for extra, in this pregnancy, they've been fine with. And so I think it's really about going in and, knowing your stuff and asking and giving a good reason and validating your concerns. But if they deny your right to healthcare, then remember that you can always find somebody else. We have providers that we work. We love Vital Medical. We trust all of the nurse practitioners there. You don't have to be working with us, but if you are working with us, you get a pretty substantial discount through Vital Medical. And I would just say, it's important to think about these things. And it's not always estrogen right away that gets put in. Sometimes it's testosterone that also can filter into estrogen and support estrogen, or things that we can do to help estrogen in other ways. But in a lot of cases, it can be very, very helpful. So just remember, always advocate yourself, follow your gut, test and address, don't guess at these things.